So today we are going to be discussing about peptic ulcer disease. We will go through the definition, predisposing factors, pathophysiology, classification, symptoms. We will compare what is the difference between gastric and duodenal ulcer. It's a question usually asked for exams or viva. And then we'll go through the management and complications. Introduction. A peptic ulcer is the loss of tissue from the lining of digestive tract. Normally, a mucous barrier protects the lining from the digestive fluids. When barrier falls, pepsin and hydrochloric acid injure the unprotected tissue. So very simple, our whole digestive tract is lined by a protective barrier. So whenever something happens to the barrier and the lining of the barrier is lost, so whichever acids are responsible for digesting our food, they come in contact with the lining of the digestive tract or the tissue, and there an ulcer is formed. Just quickly we'll go through an anatomy review. We have the esophagus, then we have the stomach. The fundus, the folds which are inside the stomach lining is known as rugae. We have body of the stomach and antrum. Then there is a pyloric sphincter. Then we goes to the duodenum of the intestine. So there is a lower sphincter or cardiac esophageal sphincter and pyloric sphincter. These are the two sphincters which are present in the stomach. So as you can see in this picture, their protective barrier is lost. So the acid which is green in color, it has come in contact with the inner tissue, and that is why there an ulcer has formed. They have shown it as stomach ulcer. And when the ulcer is present in the duodenal part of the intestine, then it is duodenal ulcer. So now we will come to the definition. Acid peptic digestion of the alimentary mucosa resulting in an ulcer is called peptic ulcer disease. This is the erosion of gastrointestinal mucosa resulting from the digestive action of hydrochloric and pepsin. So hydrochloric acid and pepsin are responsible for erosion of the protective layer or the alimentary mucosa, and hence an ulcer is formed. So that is known as peptic ulcer disease. It is a break in the continuity of the GIT that may involve the mucosa, submucosa or muscular layer of esophagus, stomach and duodenum. So there is a discontinuity. That is known as peptic disease. Next, what are the causes of predisposing factors? Neurological cause. Stimulation of vagus nerve increases secretion of acids. This is brought about by anxiety, worry, hurry, curry. So nowadays it is very much common in people who are in software workers and everything. So the main three causative factors are anxiety, worry, hurry and curry. So anxiety, you have stress, too much stress in your job, and worry, stress in your job, tension, and then having food very quickly. And curry in the sense it's extremely spicy food. So anxiety, worry, hurry, curry, all these are neurological disorders which stimulate your vagus nerve, and hence there will be increased production of stomach acid. Non-steroidal anti-inflammatory drugs or NSAIDs, they are responsible for gastric ulcer than duodenal ulcer, altering mucosal defense. So if you are someone who has been taking NSAIDs for a very long time, then they will cause gastric ulcer than duodenal ulcer. Then genetic causes, family history, patients with blood group O, they are more prone due to increased parietal cell population. So family history, if someone in your family has this disease, or patients with blood group O, they are more prone due to increased parietal cell population. So because they have increased parietal cell, they are more prone to peptic ulcer disease. Next, food habits. Food habits: spicy food, diet poor in vitamins, smoking, and alcohol alone or in combination. So if someone who smokes or consumes alcohol and then takes extremely spicy food, has a diet poor in vitamins, they are prone to PUD. Bacteriologic causes. Helicobacter pylori is a spirochetal bacteria which increases pH by splitting urea and releasing ammonia. So if Helicobacter pylori is too much in your stomach, or endocrinal causes like Zollinger-Ellison syndrome. Going through pathophysiology, imbalance of aggressive factors such as acid production, production of pepsin, and defensive factors such as mucus production. So these two are there because there is production of acid in one side, and then there is production of mucus in another side. So there is an imbalance. It's not working in equal. NSAIDs disrupt the gastric mucosal barrier, making it vulnerable to breakdown forming ulcerations. They also interfere with the protective mucus layer by inhibiting mucus activity, reducing mucosal prostaglandins, which cause abnormal permeability of the mucosal layer. So, when you are someone who has been taking NSAIDs for a very long time, the vulnerability is compromised of the mucosal layer. So, the protective mucus layer, what happens is the protective mucus layer gets more permeable and causes the acid to move inside the protective barrier. That is causing abnormal permeability of the mucosal layer because the mucosal prostaglandins, which are there to protect the mucosal layer, are compromised. Next is infection with Helicobacter pylori is the leading factor of PUD formation and is associated with all ulcers not induced by NSAIDs. So, in all those cases where NSAIDs is not responsible, H. pylori is the leading factor. The pylori colonize the deep layers of mucosal gel that coats the gastric mucosa and disrupts its protective properties. So, similarly, how NSAIDs disrupt the protective property, similarly, the H. pylori also disrupt the protective property of the gastric mucosa. So in this picture you can see how through an endoscope we can view peptic ulcer. You can see a gastric ulcer, you can see the duodenal ulcer. So it seems like a small ulcer or a wound which is present inside the stomach lining. Coming to classification, depending on the site, we have duodenal ulcer, gastric ulcer, and combined. Duodenal ulcer, where the ulcer occurs in the first inch of the first part of duodenum. First part of duodenum's first inch. Gastric ulcer occurs in the lesser curvature adjacent to acid secreting parietal cell mass. So, very near to the acid secreting parietal cell mass, in the lesser curvature, we have the gastric ulcer. The third one is combined, which is also known as gastric ulcer type 2 or Zollinger-Ellison syndrome. Okay, where we have both a duodenal ulcer and a gastric ulcer. Second one, depending upon the duration, we have acute and chronic. Acute, which is recent; chronic, which is happening for a very long time. So these are the types of gastric ulcer. Gastric ulcer types: type 1, type 2, type 3, and type 4. In type 1, in the antrum near the lesser curvature. Type 2 is combined gastric and duodenal ulcer. Type 3 is pre-pyloric and type 4 is ulcer in the proximal. You can see how many percentage chances are there. Type 1, you can see type 2 where it is combined. You have one in the duodenum, one in the gastrum. Third one is type 3 gastric ulcer and type 4. Signs and symptoms. Epigastric pain, which is burning and relieved by food or an antacid. Duodenal ulcers or dull pain and is not usually relieved by food or antacid. So that is the major difference between a duodenal ulcer and gastric ulcer. There is an epigastric pain, and when you have food or an antacid, if the pain is relieved, it's duodenal ulcer. If the pain is not relieved, then it's gastric ulcer. Persistent vomiting due to pyloric stenosis, you will get persistent vomiting and acid regurgitation along with that. Next, nausea and anorexia, common in gastric ulcers due to vagus nerve which stimulate the hypothalamus and consequently the vomiting center. So you will have vomiting, nausea, anorexia, epigastric pain, dyspepsia and heartburn due to regurgitation of gastric contents. Now, occult blood in stool due to bleeding from a perforated ulcer. There will be an ulcer which will be bleeding, and due to that, you will have occult blood in stools. Second one, weight loss due to painful gastric ulcers which occur soon after eating food. But there is weight gain in duodenal ulcers because pain gets relieved by food intake. So, in duodenal ulcer, because after you eat food, the pain gets relieved, the person will gain weight. And while in case of gastric ulcer, the pain occurs soon after eating food, so the person will refuse to eat food, and that will cause weight loss. Hematemesis, vomiting of blood. Anemia may be present in chronic peptic ulcer diseases due to hemorrhage from perforated ulcers and poor nutrition. Next up is a comparison between gastric and duodenal ulcer. In gastric ulcer, the location is in stomach or gastrum, which is common in 50 years and above. In duodenal ulcer, it is in duodenum and the common age is 30 to 60 years. In case of gastric ulcer, pain occurs on intake of food, while in duodenal ulcer, the pain is relieved on taking food. Then, in case of gastric ulcer, the pain occurs on intake of food, which is relieved by induced vomiting, and pain is of burning nature. While in case of duodenal ulcer, you will experience heartburn and water rash. In case of gastric ulcer, there is weight loss. In duodenal ulcer, there is weight gain. In case of gastric ulcer, incidence of malignancy is present, and in duodenal ulcer, it is rare. Gastric ulcer patient has a tenderness in epigastrium, patient has a tenderness in hypochondrium when it comes to duodenal ulcer, in right hypochondrium. Gastric ulcer, vomiting is common. Duodenal ulcer, vomiting is rare unless patient develops pyloric stenosis. In gastric ulcer, hemorrhage is common, often leads to hematemesis and melena, and in duodenal ulcer, hemorrhage is rare. Next is management. We have to do some investigations. First one is esophagogastroduodenoscopy. In that, the ulcer appears with or without slow or bleeding in their typical locations. In long-standing duodenal ulcers, there may be narrowing of pylorus with stasis of food in stomach suggestive of pyloric stenosis. Special radiology, which is barium meal, is done to visualize the ulcer after the patient has taken barium meal. Biopsy may be done for gastric ulcers to diagnose benign or malignant changes, and stool examination to detect presence of blood in stool, which may be sign of bleeding from the gut. So these are the images of how a gastric ulcer appears in endoscopy. Now this is gastric and duodenal ulcer. On the left side is gastric ulcer, right side is duodenal ulcer. Now this is normal barium meal in single contrast and double contrast. This is how barium meal appears in case of pyloric stenosis and duodenal ulcer. Another two images showing duodenal ulcer and gastric ulcer. Now in barium meal X-ray, another thing you can note in case of gastric ulcer is that if it is in the lesser curvature, you will see what is known as a niche, a projection sort of X-ray would be seen, and if it is in the greater curvature, a notch would be seen in the barium meal X-ray. And this is for gastric ulcers. Next is radiography. In case of radiography, it is less expensive and requires barium, and most ulcers, 90% of the ulcers, are diagnosed accurately. Now this is an image of the niche barium meal examination. Niche and notch are the two signs which you can see in barium meal examination for gastric ulcer. And last one, medical management. The aims of the treatment would be to relieve discomfort, protection of mucosa barrier to promote healing, and prevention of complications and recurrence. An emphasis has to be put on diet, rest and stress education, avoidance of smoking and alcohol. So, in diet, you have to take non irritating foods or bland diet. Neutralizing or decreasing stomach acidity, eliminating possible stomach irritants like NSAIDs, alcohol, and nicotine, they should be avoided. We should have a bland diet. Now, the bland diet will lead to speed healing, keep ulcers from recurring, and avoid foods that make pain and bloating worse. We should take antibiotic medications, acid blockers, and antacids, proton pump inhibitors, or cytoprotective agents. Surgery will be done in emergency cases, and surgical procedures include vagotomy with pyloroplasty, or Billrose 1 and 2. In case of duodenal ulcer, medical management is H2 receptor blockers, proton pump inhibitors, regular antacids, bland diet, and eradication therapy. Where surgical management would be high selective vagotomy and total truncal abdominal vagotomy with gastrojejunostomy of Mayo or pyloroplasty. In case of gastric ulcer, ranitidine we should take, quit smoking, avoid NSAIDs. Surgical treatment includes Billrose 1, partial gastrectomy, or Billrose 2. So this is what looks like in case of truncal vagotomy with antrectomy. Billrose 1, where gastrum and duodenal reconstruction takes place. Billrose 2, where gastrum and jejunal reconstruction takes place. You do the surgery and remove antrum and pylorus. This is antrectomy. The whole of antrum is removed in case of Billrose 1. This is Billrose 2, where gastrum and jejunum are repaired together. Complications of the above include in case of acute perforation, hematemesis or melena, in case of chronic gastric outlet obstruction, teapot deformity, hourglass contracture of stomach, penetration into pancreas, and carcinoma of stomach. Two main deformities which can be seen are teapot deformity and hourglass deformity. These both are seen in case of gastric ulcer. This is how they are seen. Now, in case of duodenal ulcer, they are kissing ulcers. Ulcers which are opposite from each other. Now, this is an important topic, and the main questions include what are the different types of surgeries. Bill Rows 1, 2, they are usual questions for Viva. At the same time, you might get questions like what is the difference between duodenal ulcer, gastric ulcer, and what is the common treatment, what are the complications. They can ask you very easily the difference between gastric and duodenal ulcers, which one causes cancer, which one cannot cause, which one can cause vomiting, and such questions are very common. Okay, thank you.